Thanks. Good morning, everybody. I'm Chuck, fifth-year resident here at UBC. Today, the title of my talk is Sexual Differentiation, Order and Disorder. The objectives of my talk will be to review the classifications of DSD, overview normal sexual differentiation, some abnormal sexual differentiation, evaluation and surgical management of some of the disorders, and review a few of the sexual assignments and psychological implications. I'm going to start with a case presentation. This is a story famous from 2009, brought forth again here at the London Olympics in 2012. Caster Semenya, she was a South African 800-meter runner. She won the Worlds in 2009 after being relatively unknown before that. She was investigated and suspended for presumed abnormal testosterone levels and suspicion of drug use. Right.
In 2009, 18-year-old world champion athlete Caster Semenya found herself at the center of one of the most intrusive media firestorms in sport.
With that comes rumors. I heard one that you born a man.
Unbelievable. It was a debilitating how to say, so this is wrong there. The experience of like this is wrong.
If that's the belief, she's female, she's female. There's no scientific test in the world that can turn that aside.
A world champion suddenly suspended from competition. Her career lay in ruins.
Just an interlude to the talk, I guess.
What happened?
We'll find out. You're gonna have to stay for the whole thing, Dr. McLaughlin.
I'll phone you later.
Yeah. We won't know by 7:21. So there's a new intersex term, or intersex is no longer used. Sorry, it's been changed to disorders of sexual differentiation. The old terms on the left there, intersex is now DSD. Male pseudohermaphrodite is no longer used. 46 DSD, and female the same. True hermaphrodite is now called ovotesticular DSD, and XY sex reversal is gonadal dystanesis. So what does this mean? The 46XY DSD is basically an under-masculinized male. 46XX DSD is over-masculinized female. And ovotesticular is the true hermaphrodite. I kind of look at it this way. Chromosomes determine genes. Genes determine gonads. Gonads determine hormones. These hormones need receptors, and receptors need organs. So a bit about the genetics. The SRY was discovered in 1990 from the TDF locus on the Y chromosome. This was found out between the difference between XX males and XY females. It activates downstream gene expression. Born with a bipotential fetus, an awful lot of work goes into trying to develop away from being female. The default is bathed in estrogen. Requires androgen to develop male structures, requires MIS to inhibit female structures. Gonad differentiation starts in the 6th week. Development of Sertoli cells. MIS gets secreted at 7th and 8th week. They're paracrine and asymmetrical. The ovarian pathway is secondary to the absence of MIS, and the second X isn't always required. As far as the internal genitalia, the Wolffian is a mesonephric duct. Mesonephric is important for the kidney development, and Wolffian for the male internal organs. Mullerian is a paramesonephric. This develops in the 6th week, and it's lateral to the mesonephric ducts. As far as the androgens, testosterone is present at 9 weeks. It peaks at 13 weeks. With secondary to virilization of the Wolffian duct, and it's a passive diffusion. Tissue conversion to DHT thanks to increased affinity to the androgen receptor. Urogenital sinus, prostate, and genitalia are developed. As we know, the two enzymes are the 1 and 2 for skin and hair and prostate. The external genitalia, the homologs between male and female. And we have our glands, which is homologous to the clitoris. Urethral folds is the urethral plate and the labia minora, and the scrotum is the labia majora. As far as the evaluation of ambiguous genitalia, history is important. Is there any history of infant death, infertility, amenorrhea, any maternal medications? Physical exam, any palpable gonads? Is there a hypospadias? What's the stretched penile length? As far as the hypospadias, important to note hypospadias and single palpable undescended testicle. There's a 15% chance of intersex condition. Non-palpable jumps all the way up to 50%, and it doesn't change very much between bilateral and single non-palpable undescended testicle. And it's important to note the level of the meatus for chance of a sexual disorder. Proximal versus distal is 65 versus 5 to 8%. Furthermore, with the evaluation of ambiguous genitalia, investigations, you need your CBC and your lights, testosterone and DHT, 17-OH progesterone, karyotype, and imaging, ultrasound, genetogram, possibly a cysto, possibly an MRI, possible laparoscopy, and maybe plus or minus biopsy. So the disorders of sexual differentiation that I'm going to focus on or look over today are in the 46XX DSD, just basically going to focus on CAH. 46XY, look at the disorders of testosterone production, disorders of conversion, disorders of the abnormal androgen receptors. On the disorders of gonadal differentiation, just going to touch briefly on pure and mixed gonadal dystenosis, and go over slightly the ovotesticular DSD. So to start, I'm going to look at congenital adrenal hyperplasia. 3 broad categories. There's the salt wasting category, virilizing and salt wasting. A classic presentation is usually at 10 to 21 days with weight loss, dehydration, hypotension, and hyperkalemia. Simple virilization. This is usually when the males present at 2 to 3 years with precocious puberty, and then the non-classic version, neither salt wasting nor virilizing. The famous chart of CAH and the steroidogenesis. 95% of causes of CAH are secondary to deficiency in the 21-hydroxylase gene. Second most common is 11-hydroxylase deficiency, and much more rare is the 3-beta-hydroxysteroid dehydrogenase. So 21-hydroxylase, 95% percent of all causes. It's majority ambiguous genitalia. It's pretty common, 1 in 15,000. The mutated gene is CYP21. There's been 10 different genes detected, and it has autosomal recessive transmission. This is the chart of the Prader classification from normal female to normal male external genitalia, which is used in reporting all these cases. A few pictures of some CAH. So as far as 21-hydroxylase, diagnosis is made by elevated progesterone and elevated 17-hydroxyprogesterone. It can be done by immunoassay for a more rapid diagnosis. You can also look at the urine for 17-ketosteroids. Investigations also include getting a pelvic ultrasound. You're going to see Mullerian structures. So you can supplement with hydrocortisone, supply the deficiency, suppress ACTH. You use an empirical dose until you really get to you get patient-specific doses according to the labs and blood pressure. And then as far as further treatment, I'll go into later, but possible feminizing genitoplasty, the very controversial clitoroplasty, and some of these procedures are important, which can help with fertility at a later time. And for the most severe cases, you can go forth with prophylactic adrenalectomy. So next I'm going to transition to the 46XY and overview them briefly. Abnormalities of T production, T conversion, and antigen receptors. So just looking briefly back at the chart, there's 5 major enzymes, enzymatic possibilities, all very rare as far as the troubles with the testosterone production. They're circled here on the chart. Then I wanted to just focus on the abnormalities of T conversion. There's the 5-alpha reductase deficiency. There's 40 different mutations. Gives you quite a variable neonatal phenotype, from penoscrotal hypospadias to markedly ambiguous genitalia. You'll have the absence of Müllerian structures, urogenital sinus, laboscrotal fusion, normal Wolffian structures, normal vas and epididymis. The T is needed for the Wolffian, the DHT is needed for the external genitalia. This gene was discovered by 2 groups, a little bit of debate I guess who discovered it first, but Imperto McGinley at Cornell and Walsh both discovered the 5-alpha reductase gene. McGinley discovered it in a group of Dominicans with ambiguous genitalia, the Guevadochis, which means the penis at 12. That's what they were known as. Walsh discovered it from 2 brothers in Dallas, Texas. This was in 1974.
It wasn't Walsh, it was G. Wilson. Walsh was a fellow. He just put the paper together. G. Wilson had done it, and the work was originally done by Wilson and Bukowski.
Yeah, so that's what I'm getting to next. Yeah. Yeah. So this was a human model that led to Dr. Bukowski's initial work down at in Dallas, Texas. These were his first 2 papers with Dr. Wilson. It provided a model to confirm the DHT theory of the prostate growth. He discovered it in its active form, and DHT is the active form of T in 1967. A very important discovery, ability of the prostate to make DHT by way of 5-alpha reductase. As we all know in this room, it initiated an extremely successful career, one in which here in Vancouver that he continued on at the Prostate Center. Many people in this room have led to benefit from all this, and has hence made a huge contribution to other important discoveries in prostate treatment. So pretty interesting connection between the two. This also led to the further discovery of finasteride, one of the, I guess, first real important drugs that urologists were using. 89, it was started human trials. 1-year study.
Another Canadian connection there is Roger Rittmaster, who's working in Halifax.
Oh, okay. I didn't realize that. 1-year study of this drug was quite successful, showing decreased prostate size, increased flow rates, and started to show to be a good chronic therapy for BPH. And finally, the randomized controlled trial came out, showing a significant decrease in total urinary symptom score, increase of flow, and a decrease in volume. Switching gears a little bit, 46XY DSD, looking at the androgen receptor and post-receptor defects. It's a common identifiable cause, 46XY with testes. It's going to be a spectrum of phenotypes, severity, and receptor disorder. Can go from complete to the normal female, and then partial androgen sensitivity. So in complete androgen sensitivity, you have your 46XY, you have bilateral testes, female appearing external genitalia, absence of Müllerian structures. It's usually diagnosed secondary to primary amenorrhea or testes at the inguinal hernia surgery. They're usually raised as females. Partial androgen sensitivity can give you a varied ambiguity of external genitalia, range from hypospadias to pseudovagina to gynecomastia and azoospermia. There's two types of receptor defects: a decrease in number, or normally functioning AR, or normal receptor but decrease in binding affinity. Management of these are individualized. And ovotesticular DSD, you have both ovarian and testicular tissue. Testicular tissues, but usually by way of developed seminiferous tubules. Ovarian tissue, you have primordial follicles. You can have a combination of one testes, one ovary, one or two ovotestes, and obviously the phenotype is quite varied. Quick picture of intraoperative shot of a true hermaphrodite with clamp on the uterus, bilateral fallopian tubes, bilateral ovotestes, and phenotypically this patient was male. The differentiation of the internal ducts is variable as the external genitalia. Internal ducts related to the function of the ipsilateral gonad. Potential for fertility can be possible if raised as females, and they do have the appropriate ductal structures. Mixed gonadal dysgenesis. It's the second most common overall diagnosis. Most do have a 45XO, 46XY karyotype. They can be phenotypically asymmetric, usually associated with a contralateral streak gonad. The phenotype can be anywhere from Turner's to ambiguous to rare male. You have phallic enlargement, urogenital sinus, labioscrotal fusion. Usually you have undescended testes, intra-abdominal. Müllerian structures can be present. As far as DSD and the risk for tumors, there is a significant risk in these. The highest risk being incomplete dysgenesis. 30% of cases will develop tumors by 30 years of age. Incomplete dysgenesis up to 15%. Usually require a Y chromosome to be at risk. It's usually a germ cell, malignant degeneration, seminoma and non-seminoma. So therefore all dysgenic gonads need to be removed. Found that scrotal testes are at decreased risk. A paper just overviewing that highest risk versus the lower risk cases. High risk being the complete gonadal dysgenesis, intermediate the partial with the scrotal gonad, and very low the complete androgen sensitivity and the ovotesticular DSD. So next I wanted to turn to more of almost discussion type stuff with sexual assignment controversies. A lot of this is started with the John and Joan case, which people in this room might be familiar with, from Winnipeg. David Bruce Reimer was born in 1965. He had an identical twin, thought to have phimosis at 6 months of age. He had a severe cautery injury to the penis, so much so the penis was obliterated. Not sure what to do. Went down to Hopkins and consulted with Dr. Money, who was the leading endocrinologist at the time. The decision was made in discussion with the parents that this penis wasn't salvageable, and therefore this little guy should be raised as a girl. This was the perfect control experiment for him because he had the identical twin brother. So therefore he had no R at 22 months, had a bilateral orchiectomy and urethrostomy. He was raised as a girl. He had quite traumatic visits to Dr. Money. They went down to see him once or twice a year. So much so, he would make the boys reenact, reinforcing that one was a girl and one was a boy. So one would have to play with girl toys, one would have to play with boy toys. Even in some of the papers, even had him perform sexual positions with clothes on. So one would be on, the boy would be on top and the girl would be on the bottom, to reinforce that yes, you are a girl, yes, you are a girl at a young age. So pretty traumatic, this little guy. He became, in the ages of 9 to 11, is quite confused. Didn't know what was going on, why he was thinking like a boy. Became suicidal at 14, and that was when his parents finally told him that no, you were actually you were born a boy. So at age 15, he decided to get the transformation. He underwent. He got some testosterone, double mastectomy, phalloplasty operations. Eventually, got married, was a stepfather, and unfortunately, for probably several reasons, he committed suicide at age of 38. So with regards to sexual assignment, there's two different schools of thought. Money and Associates had a proactive approach, gender-specific role play, early surgical therapy. The exposure to androgens in utero, genetic sex secondary, was specific to social context. Social and characteristics of external genitalia were the most important factors. This is against the Diamond's group, where they feel strongly about the sexual identity does not depend on external genitalia. Genetic imprint on the central nervous system, utero, and early childhood, and this coincides with post-pubertal hormonal changes, coinciding with the actual genetic imprint. So genetic imprinting is an unknown critical period during development. Androgen exposure on developing brain may be the strongest predictor. We do know a testosterone spike at 14 to 6 weeks gestation may have a factor. 46XX, the CAH, they are raised as females, but several studies have shown that they do have a more tomboyish behavior, show rough play versus other girls. There is also a documented higher rate of bisexual or homosexual tendencies. In animal studies, female rats exposed to perinatal testosterone reveal male mating behaviors. Postnatal testosterone treatments, 1 to 6 months, have shown strongly to correlate with more male behaviors as well. So sexual assignment, it's always going to be controversial. Physical, psychosocial issues are vast. So you're going to require a multi-team approach. Gender dysphoria is a term that's been is used, saying that it's a feeling that one's gender is incorrect, which I'll touch on as well. Back to our case, Caster Semenya. She was suspended by the IAAF until further studies could be performed. This case was very poorly handled by the IAAF. She was actually told that she was undergoing just standard doping tests. She wasn't told that they were looking into her sex. It was quite a bit of stress for Caster, intense scrutiny and humiliation. So this was brought to the public again, I guess, because of the recent changes in the 2012 Olympic Games. They reinstituted regulations on female hyperandrogenism. The quote here, I'll read out. In general, the performance of male and female athletes may differ mainly due to the fact that men produce significantly more androgenic hormones than women, and therefore are under stronger influence of such hormones. Androgenic hormones have performance-enhancing effects, particularly on strength, power, and speed. So their expert panel on hyperandrogenism led to several recommendations. The expert panel felt they should examine all available information and establish, 1, whether investigated athletes' androgen level measured by reference testosterone levels in serum is within male range, and if so, whether the hyperandrogenism is functional or not. So more on the rules and regulations of hyperandrogenism. In the paper states women produce 1/10 testosterone level than males. Normal range for male is greater than 10 millimoles per liter. Only females who have testosterone levels below the normal male range or who have androgen resistance conditions are among permitted to participate in women's competition. Identified athletes must undergo a clinical exam, endocrine exam, full exam including genetic testing, imaging, psychological evaluation. If they find that there is elevated testosterone, then the board presents a therapeutic proposal, and the patient or the athlete is actually banned from competition until the T is lowered. So looking at disease-specific sexual assignments on your 46XX DSD, the CAHs, pretty much 100% of these cases are given a female diagnosis. There is a difference between the salt-losing and simple virilizing conditions. Issues being enlarged clitoris, labial fusion, urogenital sinus, short vagina. This is one of the largest studies of long-term follow-up, psychosexual follow-up of 28 CAH patients. Out of the 19 patients that they were follow-up long-term, 3 out of the 19 actually questioned their female gender. More severe of the simple virilizing. More severe thoughts of questioning the female gender in the salt-losing being 8 out of 22. Majority of them underwent clitoral surgery. As far as vaginal surgery, 10 out of the 19 of the simple virilizer required vaginoplasty, and 17 out of the 22 of the salt-losing required vaginal surgery. The goals of the surgery for these patients are genital appearance compatible with gender, unobstructed urinary emptying, good adult and reproductive function. There's a lot of debate on this, obviously, but recommended timing for surgery is 2 to 6 months, or at least less than a year, and then a revision is usually required in adolescence once estrogen is on board. So controversial clitoroplasty. 1930 was the first reported case, but up in 1930 until 1970 it was actually just clitoral amputation. Dr. Pippi Sally in Toronto has made a significant contribution to this, describing a corporal sparing dismembered technique. It degloves the clitoris. The 2 hemicorpora bodies are separated in the midline. Each hemicorpus is rotated lateral and inferior to be placed inside the respective labial pouches. And the posterior vaginal wall is also able to be constructed with a combination of an inverted U-flap and excess urogenital sinus tissue for a vault. Limited follow-up and few patients, but all retained desired cosmetic appearance. All preserve their glands, which is obviously a complication in degloving and trying to preserve the neurovascular bundles. And there's been no evidence of painful erections. Looking at the 46XY DSD, looking at the complete androgen insensitivity cases. These are the patients with external female genitalia, bilateral testes, and absence of any Mullerian structures. 100% of these patients reported in the literature regard themselves as female. They're attracted to males in adolescence, so the occasional gets attracted to females in adulthood. 78% of them reported sexual satisfaction with sexual function. Surgical procedures associated with this population. Just under half usually are required to go under vaginoplasty. Clitoroplasty isn't an issue. The range of length of clitoris is 2 to 15 millimeters, which is consistent with normal. And 100% of these patients do go on to get a gonadectomy prior to the age, or they try and get it done prior to the age of 21. The first reported case of malignant transformation was at the age of 14 in one of these patients. The 5-alpha reductase deficient population, it's autosomal recessive. Again, the normal T gives you normal SVs, vas, epididymis, and ejaculatory ducts. No DHT gives you severe genital ambiguity, clitoral-like phallus, bifid scrotum, pseudovagina, perineal hypospadias, and the testes might be intra-abdominal or within the canal. These patients, interestingly, get elevated levels of testosterone at puberty. This is when they develop their secondary sexual characteristics. They get the phallic enlargement, plus or minus testes descent, and this is where the term penis at 12 was coined from the group in the Dominican. If they're raised as female, largest reports show that over half of them do undergo gender role changes from female to male after puberty. Today, now, with advances in diagnosis, these are all suggested to be raised as males. So those are the pretty clear ones. Know what to do. The cookie cutter stuff. Not so clear on what to do are the a group that I put together as the partial androgen sensitivities, the mixed gonadal dysgenesis patients, ovotesticular DSDs. Largest study out there with long-term follow-up was Mignon and his group in 2002. 14 patients with partial androgen sensitivity, 11 with partial gonadal dysgenesis, and 14 with true hermaphrodites. Out of all these 39 patients, 21 were eventually raised as men, 18 as women. So looking at the group as a whole, the patients in the upper graph were those patients who were raised as females. Important to know the difference. The median ORs for these patients was 2 total ORs during their lifetime, and did report quite a low self-reported body image, versus those who underwent male diagnosis had multiple ORs, anywhere from 0 to 10, many having more than 10, and again, I reported quite a low body image when asked. Looking at the 2 groups on more of a psychosocial aspect, the graph on the left reported self-reported sexual orientation in participants who were living as men or women. This scale was used to help indicate sexual attraction and experience. So the 0 being sexually attracted to women only, 3 were women and men, and 6 men only. Dominant that the males did say they were most sexually attracted to women only, and a bit of a mix with the female group. The graph on the right or self-reported degrees of masculinity and femininity in participants living as either male or female. For the males, they were using a grading system as 1 not masculine at all, 3 somewhat masculine, 5 highly masculine. So pretty diverse reporting as far as masculinity and femininity. So after all this discussion, there has been recent and kind of probably always will be talk of a surgical moratorium. Several groups are proponents of this, led by a group, the Pacific Center for Sex and Society. They're calling for all surgeries, unless medical emergencies, should be delayed until the child is actually able to make its own decisions. They feel strongly that that surgery is damaging, mutilating, and strictly cosmetic. So DSD, it's always going to be controversial. We always have to consider the psychosocial well-being of the patient, gender identity, sexual appearance, looking at sexual function, and if possible, fertility, and trying to minimize the number of surgical procedures. Castor, she was the South African flag bearer at the London 2012 Olympics, and she won the silver medal in the female 800 meter race. Thank you very much. Thanks to Dr. McNeely for helping me with this presentation.